Welcome back to Right at Home's Ask the Expert series, where we interview people in the senior care community and health experts on topics that are important to those with with an aging loved one. And as with previous episodes, if you like what you see, we'd love you to like and follow our channel so you can learn all about issues that are important to folks with an aging loved one. And today we're talking with Alice Allen Redfern, co-founder and head of clinical services, and Dr. Lama Sibai, head of medical services at Nolia, an all-inclusive support organization that provides resources and guidance to adults living with chronic conditions and supporting them along with their care team. So I want to welcome you both to Right at Home's Ask the Expert.
Thank you.
Thanks for being here.
Thank you.
Happy to be here.
Yeah.
So we're going to learn a little bit about Nolia and specifically a new program covered by Medicare that you guys are launching today. July 1st.
Yes.
First here in Washington State, called the GUIDE program.
Mm-hmm.
But first I want to welcome Alice and Dr. Sibai. So why don't you each introduce each other? Alice, you want to go first, I guess as the co-founder, and
Sure.
let us know a little bit about yourself and your journey that led you to forming Nolia.
Oh my goodness, absolutely. So I'm Alice. I'm a licensed clinical social worker at Nolia Health. I I've been in the aging field for over 10 years. I specialize in palliative care, aging adults, caregiving, and I would say the founding story has to kind of include both of us.
Okay, that sounds good.
So, I was at the Alzheimer's Association here in Washington State 7 or 8 years ago, which is where I was supporting families living with Alzheimer's disease and related dementias. And that's actually where I met Dr. Sibai, who is down at Valley Medical Center, which is a community hospital down in Renton. Dr. Sibai pioneered this dementia clinic. Why don't you tell a story a little bit about how that sounded?
Sure. So yes, I'm Dr. Sibai. I am a neuropsychologist. I specialize in dementia and movement disorders. Like Alice, I've been working in this space for over a decade now, supporting families, patients with neurological conditions, and walking them through that journey. And I think our story begins, I left fellowship and came here to Seattle to take a job in the neurology department at Valley Medical Center, where I was a provider. And shortly after starting there, felt like neurology is a diagnostic practice. And oftentimes we are giving diagnoses that are not just life-altering for the person living with the condition, but really seem to have this ripple effect and it moves throughout the family and the support systems. And traditionally, appointments are geared so much towards the patient and their care and their needs, which is very important, but we're missing sort of a really big pillar in our healthcare system, which is the family caregiver.
Exactly.
And so I felt dissatisfied with what we were doing. I don't want to just be a diagnostician. I want to help people on this really complicated journey. And so I started a dementia program there that didn't exist there or really anywhere else, where realizing that we can't all do this alone. Even as a healthcare organization, we didn't have all the folks that we needed on a team to really support people on this journey. So I reached out to the Alzheimer's Association, recognizing that these community-based organizations and healthcare systems, they're not talking. I need to bridge that gap. I need to get people the resources that they need. And I'm also not a social worker, and our social workers are like the glue of our communities. So that's, Alice came to work with me, and I think we just had similar visions and minds, and we just kept building the clinic more and more, and there was such a need for it.
This was within Valley Medical?
Yes, initially.
Okay. Got it.
And we got, we had a wait list for like a year, which then I come back and I'm like, this is a problem again, because access to care is needed, and this is clearly a needed service. I think there's a lot of benefits in proving out the model of care. While we were working at Valley, we got to collect data for 8 years, both qualitative and quantitative, just to see what kind of help, does this support provide, not only the person living with the condition, their families, but the healthcare system at large, which is suffering from these admissions, that people coming in using the emergency room as a safe space because they don't know where else to turn. So we were able to reduce emergency room visits by 52% within the first year, which is a massive thing for
That's
healthcare
amazing.
systems.
The administrators there must have been happy.
Yeah,
Saving them a lot of money.
yeah. And
Right.
and on the other side, patients were doing better,
Right.
families were doing better, we were reducing caregiver burnout. So all the outcomes that we would hope for came out of that. And then we just wanted to make it more accessible. I love serving the community in South King County, but there's a lot of dementia deserts out there, and there's a lot of people that don't have access to this specialized care. So we decided to work in parallel with the existing healthcare system to come in and fill in the gaps and provide this extension of care for folks. And that's how Nolia Health
That's how
was
Nolia
born.
got started.
That's where it is.
Yeah.
Wow, that's really amazing. So, so obviously you told us about the mission and the problems you're looking to solve with the organization. You definitely covered that. So let's talk a little bit about this new program that is launching today, the GUIDE program. What is the GUIDE program and why was it established?
Good question.
So I can take the lead initially. The GUIDE stands for Guiding an Improved Dementia Experience. It's a brand new program that has come out of the Centers for Medicare and Medicaid. Last year it was announced, right? And for us it starts today, July 1. Really it is a brand new Medicare benefit. Just like I'll compare it to a hospice benefit. If you're end of life, you are eligible for this hospice benefit. This is now a brand new dementia Medicare benefit. If you are on this journey and you have, we can talk a little bit more about the eligibility criteria, but if you have Medicare as your primary payer and you're on this journey, you are eligible to access this benefit. The reason, the reason that it came out was exactly the reason why we started Nolia Health.
Sounds like there's a parallel there.
And you can imagine when the Centers for Medicare and Medicaid sent that email into our inbox last year, I called Dr. Sibai and I was like, have you seen this? And it was this sounds a little dramatic, but generally we had tears in our eyes. That essentially what it meant to us is that it was a national acknowledgement that things need to be better. The three goals of this program, of this benefit, is improve the quality of life of the person living with Alzheimer's disease or related dementia. It is reduce caregiver burnout, and it's to keep families where they want to be in the community, right? In their homes or in a place where they're still connected with their family and the people that are taking care of them. So I'm sure we'll dive in a little bit deeper around what this Medicare benefit is. But the reasons are, too many people on this journey, at best, they might get a diagnosis of a certain type of dementia. They might have that, but they're often just then sent away to navigate this on their own. This benefit means that won't happen. They will have a dedicated team of clinicians to carry them through this, that will, provide that clinical expertise, that practical support, and that emotional support.
Can you give me an example, maybe of someone you've worked with, or maybe a theoretical person that you have in your mind's eye that kind of what it would look like with the GUIDE program and what it would make kind of looks like currently without them having to negotiate all these resources on their own?
Yeah, so why don't we start there? Why don't we start with what this looks like today, or and before the GUIDE was introduced? What I want to say is that prior to the GUIDE, there was no standard of care for how we approach dementia, besides a diagnostic sort of list, but what we do afterwards. And so what I love about this program is now there is a standard of care. And what it highlights, as you saw, was that nobody can do this alone. Not one clinic, not one provider, not one community-based organization. It forces collaboration. And that's really necessary because in the current healthcare system, best case scenario, you go to your primary care doctor, you are in a wellness visit, which starting at age 65, you should be administered a cognitive screening measure as part of your visit. So let's say best case scenario you do, and you find that you score below a cutoff. The next step there is to get labs done, to put in a referral to neurology, to sort of do an investigation of what's going on, typically labs, imaging, so on and so forth. And then you get to a neurologist. Unfortunately, the wait lists are a problem, right? Sometimes people are not seen for 6 months to a year after a referral has been placed. Sometimes they fall through the cracks because there's a lot of pressure in the healthcare system with staffing and all the changes going on are trickling down from the administration down to these entities. So, at best, you'll get a diagnosis, as Alice mentioned. What to do after that? Maybe some clinics can hand you a pamphlet, a website, and you're really set off to navigate this journey, on your own, which is kind of, wild when you think about it, because I, as a clinician who specializes in this type of care, can't do it alone. So why would somebody else be able to do it alone? So that is kind of the common experience that people get right now. And then with Guide coming on board, what we're hoping is this will encourage early detection and diagnosis, first and foremost, getting providers comfortable with understanding what the dementia process looks like and how to diagnose it.
And I will just say, and the reason for that, right, is because there's so many reports and statistics out there that clinicians don't. They might do a screening in the primary care office, but they don't go further than that because their thinking is, well, there's nothing for the families to support them. So why am I going to put them through all of this when there's nothing there? Now, suddenly, a program that, again, is at no cost to families is available. So, I think that's a huge connector that the Center for Medicare and Medicaid recognized that is such a barrier to support.
So doing more will actually provides benefit to folks.
Absolutely. I mean, I think generally speaking, if somebody comes in with a diagnosis and they qualify for Guide, we can plug them into services immediately.
That sounds great.
Yeah.
Well, why don't we dig a little deeper into that? So why don't we talk a little bit about what are the steps involved to qualify for the Guide program?
So I'll just back up a little bit and say that this Medicare benefit, this program, Guide is something that as an organization we had to apply for. So we had a lot of criteria that we had to meet in order to tell the Center for Medicare and Medicaid that we can provide dementia specialized services. So I just say that because, it's not like you can go into your primary care and say, I want to access Guide, right? We partner with primary care.
So you have to do with what are called participating organizations, correct? And so Nolia is one of, and I think it's a closed, they did the application process. There's 350 some odd folks that
across
were
the nation.
And then during this 8-year pilot program, that's it. Those are the folks participating in the program.
Precisely.
So, that is why Dr. Sibai and I are out in the community a lot, because it is kind of on us as providers that got accepted into the program to let other clinicians, primary care, which, let's be honest, that is where people go for most of their care, that they know that this is available. And we always say to caregivers and patients that come to our talks and to our presentations, go and advocate and say, this is a program that exists. So, we just want people to know that it's out there and it's available. So in terms of kind of eligibility, so someone say watches this, finds out about Guide and is interested. What they can do, they don't have to go to their primary care. They can call us directly. We don't need a referral from another provider. They can call us directly. There are some eligibility requirements that we will make sure that we go through. So off the top of my head, one of them is the individual living with with Alzheimer's, memory loss related dementia has to be in Washington, right? We are right now a Washington State provider. Okay. The caregiver, the family caregiver, if that's a adult daughter living in New York, that's totally fine. We can still provide support to that person, but the individual has to be in Washington State. Okay. They have to be they have to have Medicare as their primary payer, parts A and B. So this is a confusing one, right? Because at the moment, when we look at kind of the landscape of Washington State, I would say right now it's 50-50 in terms of over 65. People are either primary payer Medicare or they have a Medicare Advantage plan. And those folks in the Medicare Advantage plan, unfortunately, won't be eligible for guide. However, hopefully we'll come to later on in this
Right, I understand
interview.
there may be resources available to them with a copay.
Yes.
Exactly.
Yes.
So,
precisely.
Yeah. So this specific program, it's Medicare Part A and B as their primary payer. Our lovely scheduler, Sarah, is wonderful because I think sometimes it can be confusing about what plan we have. We have a lot of families that call in and say, oh, I'm not really sure which plan mom has.
Right.
We're able to check that before.
And what information they need to provide? Is it just their full name and their Medicare number?
Pretty
Or
much, yeah.
do they
That's
need
what you
any
can look
other PHI health information they need to provide
Not
with you
to
as a
check
client?
that specifically.
Yeah, not
Just
for
to
that.
determine whether they're eligible or
Right.
not. Just your full legal name and your Medicare number is all that's required.
Yeah, to look it up in the
Okay.
system.
Got
Yeah. They do have to, in order to get access this program, have a dementia diagnosis, right?
Okay.
So this is a big one. And when we say dementia, we mean a very, well, you know what, I'll have the doctor explain what we mean by that.
There's
What
a
is
lot
that?
of different, yeah.
There
I
is.
know. It's confusing because out in the world we use terminology interchangeably. For example, we use Alzheimer's and dementia interchangeably. So when folks hear the word dementia, they automatically think Alzheimer's disease. And the way we like to describe it is dementia is an umbrella term. It is a set of clinical symptoms. So, for example, to get a diagnosis of dementia, you show some level of cognitive decline that is now getting in the way of your day-to-day functioning. So now I need reminders to pay my bills, or I need help managing my medications because of the cognitive decline. That gets you a diagnosis of dementia. But that doesn't tell you the cause of the cognitive decline. And so under that umbrella of dementia, there are several conditions that can cause dementia. So Alzheimer's disease is the most common one once we hit 65, which is probably why we hear about it used that way interchangeably. But Parkinson's disease can cause dementia, and multiple sclerosis can cause dementia, and there's all alcohol-related dementias. And so the etiology, or the underlying cause, is the disease that causes dementia. So I think sometimes that confusion creates stigma, which gets in the way. It becomes a barrier for people to get diagnosed.
Does that different types of dementia will impact your eligibility for the program?
No. So what's beautiful about this is any kind of dementia qualifies.
So you might have gone to a provider and been diagnosed with Parkinson's-related dementia, vascular dementia, Lewy bodies dementia, right? The Center for Medicare and Medicaid has made this very vast, which we're very thankful for. If someone comes to us and says, well, I don't have a diagnosis, but I know something is going on,
Right.
what we'll do then is make sure that they meet either with our nurse practitioner or one of our neuropsychologists. We can provide the diagnostic test. We can get that dementia.
What happens if they
diagnosis.
come already from their neurologist?
With
Like
a-
I know I've talked to some skilled nursing facilities, right? And I've been
Yeah.
talking about the guide program and introducing it to them. And they say, I already have from the clinician a diagnosis of dementia. Do you have to go through, does Nolia also have to do an additional
No, absolutely
test?
not. We would never put someone through something that they wouldn't have to do. So what if that's the case? We would just ask a few questions of who was it that diagnosed, when was the diagnosis. If we could get hold of them and get that paperwork over, great,
That
just
makes-
because it gives us some information. If not, our clinicians can still attest to that. We're not going to put them through more testing that they don't
Okay,
need.
well, that's
Yeah.
important to know.
Absolutely, yeah. And the other piece, if you look up on the CMS website around this program, there is something that says mild cognitive impairment, or MCI, makes someone ineligible for this. Which, it's that can be a difficult topic, and I'll have you kind of explain why that's an important piece to
Yeah, it's important, and I think this is why I'm grateful that we have Nolia Health, because even if folks come in and they don't necessarily fit the guide criteria, we don't need to turn anybody away.
Oh, that's good.
So a diagnosis of mild cognitive impairment is often the precursor to dementia. So I think 80 to 85% of people end up developing dementia over time. When that happens is hard to say because it's very case by case, and obviously depends a lot on your other health issues if they exist. But we want to see those people. We want to be preventative. Our mission here is to prevent things. While you may have a diagnosis, and that it seems, weird to say, be preventative, we can prevent a lot of crises from happening. We can slow down the progression of these diseases. And so when we get to work with folks who are in that MCI phase, they still need support. They still need guidance. They still need help. And so, they might not qualify for guide, but we're still going to take them and be on this journey with them and help them sort of navigate this. And the earlier, the better.
Okay, that's good.
We just don't want to scare anybody away because I feel like that mild cognitive impairment, it's a gray area.
You're right.
So we don't want that to
still come talk, and then there's still there'll be resources available.
And what I find sometimes is somebody's had a diagnosis of MCI for 2 years, and then nobody has checked up on it. So one thing we can do is screen them again and see, have we converted into that space, and then you would be eligible for guide.
The program.
Right.
Okay.
And then just the last 2 pieces around eligibility is folks on hospice wouldn't be eligible or the PACE program. And the reason for that is there's so many duplicitous services when it comes to guide, hospice and PACE. And then the individual can't be living in a skilled nursing facility.
So they could be transitioning, let's say their short-term stay in a skilled nursing facility, look to transition home, but if they're living in a SNF, then skilled nursing facility that doesn't good.
But if they're in assisted living or memory care or an adult family home, they qualify.
They do qualify. Oh, that's really, it's amazing.
Yeah. And then I just think the last, because we get a lot of questions around this in the community, is that there's no other kind of federal program that disqualifies you. So people could be on COPES, people could be getting benefits from the Family Caregiver Support Program, different, and you can get, they're a complement to each other.
I wonder if you're a veteran, because a lot of times the VA is providing some of these resources in their kind of Byzantine way, you know, 'cause it's kind of hard to navigate.
Yeah.
Is this program also available for veterans?
They have Medicare as their primary payer.
Medicare is their primary care. So they're on TRICARE. Is TRICARE also qualify?
It has different plans. So a lot of the families that we know who get access healthcare support through the VA have Medicare, and then TRICARE is their supplemental plan.
Oh, okay.
So yes, they would be benefit. If TRICARE is their primary payer, then no, they wouldn't be eligible for this. So it's a little bit nuanced. And again, this is why we're always just call us and we'll figure out.
We don't think this is not something that we expect families to figure out.
Right.
Yeah.
We just call us. We are triaging on the phone in real time. Listen,
So don't worry about it. Provide your Medicare number.
We'll figure it out. If you come to us and you qualify for guide, we are funneling you into guide, because why wouldn't we?
Right, exactly.
It's going to come at no cost for people.
And it's not going to be, I've had people ask me, well, is this going to interfere with my Medicare home health benefit or some other, there's no concern if I participate in guide, it will keep me from being able to participate in some other Medicare Part B program.
No, and that's a really important point, Ben. This is a voluntary program. You don't have to go into it. And also, we're not taking over any care. It's not replacing anything that's existing, right? It's an extension to what you're already getting from your primary care or from your other specialists. A big part of guide and a big goal of it, and a big goal of Nolia Health, is to combat that fragmented system that we know exists in this space, right? So it is our responsibility to, when people do come to us and we enroll them and we establish them here, we are connecting with their primary care. We are connecting with any other specialist involved. So everybody is on the same.
So you're not taking over their primary care. You're connecting with their primary care and all their neurologists or whoever may be part of their care team.
Yeah. And actually, we are looping back with everybody. So their other providers may not even know that they're in the guide program or know about the guide program. And so by having that bi-directional conversation.
So the navigator would figured out that pieces of data, who's everyone on your support team, you'd put that in your database, and then you'd be communicating out so everyone knew this is what's going on.
Yeah.
Well, that's great. Yeah, that's super important.
Yeah.
What's the time between each step? So they come in, they give you a call, they're like, okay, do I qualify from an insurance standpoint? And then if they don't have a neurologist or some clinician who's kind of have a clinical exam for them, and then they have to, I guess what does that look like?
If they don't have the diagnosis.
Well, let's say they don't have it, like something's going on, or they don't have a clinical
so we have a couple of appointments at Nolia Health that help us figure out the diagnosis, So typically we will screen them, and if their score is in a certain range, we just know that.
Are there certain tools that you're using? Would it be of interest
a cognitive
to people
screening
listening
measure,
here?
the one that we use mostly is the MoCA.
Okay.
We say that in the community. Everyone's like, it's the clock. So like that is
there is a clock on there. There's other things on there, but it's like a quick snapshot of various different brain functions. That's what we're capturing, and just trying to understand, are you where you need to be? It's a screening measure. So oftentimes we'll give it and realize we may need a full battery of cognitive assessments.
Maybe more than just that.
Yes, because then we can understand the etiology. Then we can understand, is this an Alzheimer's type dementia? Is this dementia due to your Parkinson's? Is this a vascular dementia due to, some findings on the brain image? And that helps us cater our care better to folks.
Just from a process, because people want to know, like, okay, I'm agreeing to this. How much is that all done in one session? Is that done in multiple sessions? Is this going to take an hour? Is it going to take 15 minutes?
Yeah, so I would say
what does that generally look like?
A screening measure appointment would be an hour.
Okay.
If we do a full battery of tests, I would say anywhere between 2 to 3 hours, depending on the patient and their needs and sort of.
And then maybe over a couple of different sessions.
Yes.
That wouldn't be sitting at once.
Well, no, we do the cognitive assessment in one session, and it's fine. It's not usually.
Now, are you coming? Is there times where you're coming to the participant's home, or is this all done on Zoom or done on Teams or some type of?
Yeah, so all of our services are via telehealth, and again, this goes back to our mission of providing equitable access to care. So we know that mobility is a barrier, transportation is a barrier, where we live can sometimes be a barrier to getting care, and we don't want that to get in people's ways. So by providing things via telehealth, we can reach anybody in Washington.
So this can all be done, someone sitting on their couch or in their easy chair, and they can just they don't have to get up and go somewhere and
Absolutely.
get dressed.
Exactly. Just from the top up.
Yeah. And so, after that, I would say, then we have the diagnosis, then we have the, would it be helpful to talk about timings around like enrolling into the guide program specifically?
Yeah, so I'm kind of curious. If someone calls up like, so what is that time? I guess obviously depends on setting up, people have busy schedules or
maybe
they don't get back to you or like.
We should talk about the time to get a diagnosis because that's kind of a major pain point right now in healthcare. But like I mentioned earlier, you may get the primary care who does the screening measure, who puts in the referral to neurology, but neurology is like backed up for a year. And that's not helpful. So we can get people in. If you come to us or somebody sends us a referral, you're going to get a call within 48 hours to assess sort of what are your needs and what is the best appointment for you. And if it is a cognitive appointment where you need a diagnostics, then we can usually get people in within a couple of weeks or so.
Oh, okay. So you can probably have this whole thing completed within 4 weeks.
Yeah.
The diagnostic piece. Yeah. Oh, absolutely.
Yeah, for sure.
And once the diagnostic piece is completed, then what happens?
So that's when kind of, the guide journey sort of starts. So what needs to happen is now that we have this diagnosis, whether it's from another provider or from us, the family, the individual, and whoever is a part of their team, their initial appointment will be with Ebony, who is our nurse practitioner. This is where she will kind of explain what the program is, explain what's involved, and just kind of get them established. That's where she gets the primary care, any other specialists, who's involved, what are the family members here that you think might want to have been here, who should we be communicating with, medication. We have to list their medication. And she will reconcile that, as a geriatric specialist, she'll sort of look at that. Many people may have been on medications for years and years and that hasn't been looked at,
or maybe contraindications between medications.
Absolutely.
Which is huge.
I get dizzy when I take it. Like,
and that's actually a really important issue in this population of folks. So that is medication reconciliation in general is like a really important piece of the care.
Yeah. And it's something that the Center for Medicare and Medicaid is overseeing due to this program, right? Which I think is great. We get dinged if there is some contraindicative of this population. So again, it's kind of holding us to that standard of care that we should have been doing many years ago. The other thing that Ebony is doing is screening for, anxiety and depression that we know looks very different in this population, caregiver stress. What else is she doing? Just essentially building that rapport with the person. Many of our families call in with concerns that, okay, well, my loved one doesn't really know that there's anything wrong. They're actually quite resistant to support. And how am I supposed to get them involved? Our clinicians are trained.
For those that don't qualify for the guide program, what options are available to them?
Yeah, that's a great question. So what I would say is all the services that are under guide, we essentially at Nolia Health, we provide. The only difference is the guide program is giving families $2,500 a year to pay for respite. So that is the only piece. Unfortunately, Nolia Health can't give you that, but as far as all the other services are concerned, you're still going to get that care.
And what does that respite piece look like?
So it is a pass-through amount. So I'll let Alice actually explain it. I feel like she's in the background there.
Yeah. So this is kind of, a very innovative piece of the guide benefit. I don't think I know, historically Medicare has not provided dollars amounts to be able to provide on respite, but we know how important respite is for caregivers to take that break and make the situation more sustainable. Right. And so what that looks like is for those who are in the mid to late stages of the disease, they're eligible for this $2,500. And so as an organization, we have had to partner with organizations in the community that's providing this respite. So like Right at Home, we as our one of our official partners, we are able to, and again, it's a pass-through amount. So Medicare gives us that dollar amount and we can then give that to you in order to provide this for our families. It's a pass-through amount. If everything goes well, the family, the caregiver, the patient, they don't see that invoice. It's a pass-through amount for. And
you have to work with a licensed Washington State agency. My understanding, you just can't hire your niece or your nephew or your granddaughter to provide the respite.
And it's important for two reasons. One, again, it forces sort of that collaborative approach. It's making organizations partner together, which is really important. And these are folks that are vetted. So, you want to make sure the person you invite into your home is, ready to do the work accurately. So that gives us the opportunity to make sure that that support is appropriate.
So as people are looking, you said, I think you may have mentioned that there's a couple a couple of participating organizations in the state. If people are looking to make a choice, and obviously choice is important.
It's very important. And I think we sometimes hear from families that they feel like they were sort of placed somewhere or told they had to do something. And just as a general rule, your healthcare is a choice, and who you see and who your provider is always a choice. So yes, that's a very important.
But as you're making choices, it's good to kind of know why Nolia. So why don't you give our audience a little bit of a understanding of why Nolia is maybe their best choice.
I mean, yes, we do believe that Nolia is the best choice. And I think we've had the privilege of providing this kind of care for over a decade now. What Guide has presented as the standard of care for those living with dementia almost exactly mirrors the program that I developed almost a decade ago. So that means we've been practicing this kind of care for a decade. We've been able to establish ourselves in the community, establish partnerships, build that trust. And so I think we can just navigate this a lot easier because we have that experience.
That sounds like a good reason.
Yeah. And our clinicians too, we're a clinician-led company. That should be a really important piece here. There are a lot of folks doing similar things out there, but that are not necessarily clinician-led, and that's important. You want a clinician to have an eye on what's going on and how it's being
the philosophy and how it's being run.
Absolutely, and that also means that our clinical team we're very intentional who we bring on to our team, and everybody has clinical experience in this population with these conditions, with these sort of unique things that come up for caregivers and how to navigate all that.
Sounds good. So the next steps is to give Nolia a call. Their phone number and contact information is at the bottom of this video. Also, you can give us a call at Right at Home, and we'll talk to Sarah and the folks at Nolia and get that help qualify that for you as well. Be happy to do that.
Yeah, and just remember, you don't need a referral from your provider. Self-refer is completely fine.
That's great. It's really important. Self-referral. So I want to thank you, Alice and Dr. Sibai, for joining us today at Ask the Expert. And tune in later for the next episode. Thanks, everyone.
Thanks.